we are trying to reach out to the students of MBBS who did not have much exposure to PMR. I would like to inform you that during this lecture, I will not be reading out all the slides, so you can always pause the video and read the details. We know that MBBS teaching is not comprehensive. It does not address many aspects of the causation of disability as well as rehabilitation. And many medical colleges and hospitals don't even have departments of PMR, or even if they have, they don't have qualified specialists of PMR. During my MBBS in the early 70s, it was very common for us to see patients with stroke in their late 70s or 80s. The only thing we learned was demonstration of the neurological signs done by our seniors. And the second thing which we remember very clearly, the advice given to the relative of the person affected on the side of the room to say, please take him home and look after. It is very less likely that the person would be able to live much longer. They would basically be confined to bed. Not knowing that with the interventions of rehabilitation, almost 70% can walk again and 40% can return to work and have a earning. So we are depriving those people the good life which rehabilitation can give. Definitely there is a gap between what was known to most of the doctors or is known to most of the doctors. Like in acute stroke, many neurologists would look after their acute condition, diabetes, controlling hypertension, controlling their vitals, and then they will send the patient home without much clue. Many orthopedic surgeons or general surgeons who do amputations would at the most give, if at all, some form of an artificial limb. But giving limb alone is not enough. PMR continues to work beyond the acute care till the person gets back to his functioning, and we try to give the quality of life to the person. So that is the good thing about PMR. To understand how rehabilitation is done, if we see the example of how a disease is caused after an etiology and pathology, similarly, we will try to understand the genesis of disability. We know this equation, and in case we go further, the disease has some form of symptoms which might be impairments, and the impairments lead on to the limitation of function, and because of the limitation of function, disability is caused. We will take example. Say a person had an accident and his leg was crushed, which is the disease. The impairment can be done surgically, or the limb was very badly affected that a person was not able to walk and therefore not able to go to work. So you can equate that with the different aspects of impairment, limitation of function, and disability. Similarly, in stroke, in case because of an ischemia, the person has a stroke leading on to hemiplegia, which is paralysis, also known as an impairment. The impending difficulty to walk is the limitation of function, and the person will not be able to go meet friends or go to work or go for recreation, etc. That is the disability. Going into the definitions, the impairment is an anatomical, physiological, or psychological loss and or abnormality. The examples are given here. It can be temporary or permanent, depending upon the kind of condition. Limitation of function, also known as the activity limitation. The key word here is difficulty to perform a function or an activity resulting from an impairment. For the legs, walking; for the hands, holding; for the eyes, seeing, etc., etc. Disability is also known as participatory restrictions. The key word here is inability to perform the role of that human being according to his age, sex, and social background. So you can see the examples down here. To understand the prevention of disability, we know the primary and the secondary prevention. So the tertiary prevention is prevention of disability, even though impairments may be permanent or temporary. For the loss of leg, if you give the artificial limb, the person will be able to walk and go to work also. Therefore, he will not have limitation of function as well as no disability. And we see the equation, the person will have no disability but may have an impairment. So we are trying to prevent disability here. Because of an ischemic stroke, the person has paralysis. In case you control diabetes or the bad lipids, the pathology of the stroke is definitely reduced, or the chances are reduced. So you're doing primary prevention. If you give TPA as soon as the person has an ischemic stroke, the disease can be reversed to some extent. In case paralysis is there, you try to address paralysis giving exercises, braces, cane, so the impairment can also be reduced. Difficulty to walk can be reduced. The person is able to walk, therefore no functional limitation. Similarly, the person would be able to perform his social responsibilities, so disability would also not be there. So in a way, the person's even disease process can be reduced down, and some patients may even come back to normalcy. Rehabilitation is defined as a combined and coordinated effort. So when we say combined and coordinated, that means more than one person is involved. So we are trying to restore the person back to his fullest physical, mental, social, and vocational aspects. And that may not be possible fully, but we are trying to do it as far as is possible. So remember these four aspects to be tackled in rehabilitation. The purpose is to make the person get back to the society and live his life fully. These are a few conditions which we commonly come across. The list is not comprehensive, so you can definitely go further and read the details. The principles of treatment and rehabilitation are primarily based on the assessment of the deficits and the remaining abilities. Our purpose is to reduce down the deficits and improve the function so that the person can be brought back to his life full functioning in the society. The goals which the doctors look at is to reduce down the impact of illness, reduce down the pathology, prevent the complications, and in case complications occur, treat them. Many times associated illnesses like diabetes, hypertension, infections, fevers, they also occur with these conditions like pressure ulcers. So we try to prevent and treat them. Wherever surgical interventions are required, even revision of amputations or doing the flap surgeries for pressure sores, surgeries for CTEV, etc., depending upon the facilities the doctors do. The impairments depending upon what kind of difficulty the patient is having. Different disease processes have different kinds of symptomatology. So we work according to what is required: medications, exercises, aids and appliances, surgeries, splints, artificial limbs, and definitely provide the person training into the performance of day-to-day activities. Most important thing is for the person to understand what is wrong with him and what is to be expected. So psychosocial counseling is one of the very important things. The person has some ability to work, so maybe we need to modify the kind of work or give some aids. At the same time, in case it's a student, we try to target the kind of education so that the person is able to do it commensurate with his disability so that he becomes an earning member of the society later. This is the combination of various team members so you can go through at ease, because there are so many aspects of the person which are to be addressed. So number of team members, including the doctors who are the physiatrists and the allied healthcare workers down below. So they also help the person to have rehabilitation. We all know that the government also provides reservation in education and jobs for the persons with disability. There are various other schemes of the government to give benefits to the persons with disability. For availing those benefits, we need certificate of disability. PMR is a core subject which provides a disability certificate. We were the ones who laid down the norms for certification, and they have been modified from time to time. The physiatrist is qualified into in doing MD or DNB in physical medicine and rehabilitation after doing his basic MBBS. He is a key person in the rehabilitation team who plans and coordinates the treatment. We work not only from the ICU to the community, but many a times in the congenital conditions, right from the birth to the rest of the life of the patient, in case the disability or the disabling condition is permanent. So we provide, in a way, long-term, lifelong support to the person. The PMR is the beautiful branch of medicine. One important thing which can be noticed is that it is not bound to one system or the organ. We work on the person irrespective of the kind of disease or the condition to improve the functioning of the person. We try to achieve better quality of life to let the person live his life. The most important thing we can see, the beauty of PMR, is almost every household has a person who can be benefited from the PMR. So never underestimate this beautiful branch of medicine, physical medicine and rehabilitation. It is one of the very important aspects. Thank you very much for listening to me.